obturation and lateral condensation technique. So the objectives of your obturation is the final step of root canal therapy, your non-surgical root canal therapy. The goal is to make a three-dimensional fill that fills the entire root canal system and complex anatomic pathways completely and densely. This is a little typo on this. You want to seal the canal system coronally, apically, and laterally. And you want total obliteration of the canal space with an inert, dimensionally stable, and biologically compatible material. You also want to create a watertight seal along the length of the root canal system and to prevent leakage of microorganisms and their byproducts coronally. And apically, you want to prevent periapical tissue fluids into the root canal system. So we want to make sure when we're looking at our anatomy of the tooth that nothing is coming in coronally and nothing is coming in apically, right? And we want to allow the prevention and healing of apical periodontitis, which we talked about earlier this morning. So as far as criteria, what's the criteria for us to know that we are ready for obturation? Patient signs and symptoms. So as we learned earlier, a patient may present to the clinic with an acute apical abscess. And if that acute apical abscess is not subsided, then obturation, when we're ready to do our obturation, that is a contraindication for obturation. Okay. Another contraindication would be the patient, any type of swelling at all, lymphadenopathy is also a contraindication. If the patient, let's say, if it's a foul odor, once you remove the temporary filling material, if it's a foul odor coming out of the tooth, that's a sign of a really bad infection. So you definitely are not ready to do your obturation. So those are just some things to look for. Tooth is asymptomatic. You want to make sure the tooth is asymptomatic. The canal is dry. For instance, if you have a canal and you have pus exudate that is coming out of the root canal system, out of the canal, that's an indication we still got bad infection going on. So obturation is out of the question. Status of the pulp, periapical tissues, the degree of difficulty for you to perform root canal treatment on the patient. It could be patient management issue going on. For instance, if you have a patient that has a TMJ problem, okay, they can't keep their mouth open for a long period of time, so you have to make sure that you limit the time span that the patient keeps their mouth open to like 45 minutes to an hour. So if you spend like an hour doing your instrumentation, you don't have enough time to do your obturation in that particular appointment. So set up another appointment to see the patient. Okay, that's just an example in patient management. So what are the components of obturation? You have your core material and you have your seal. We use gutta percha. That is the standard of care for endodontics, to use gutta percha. And seal. There are many different types of sealers on the market. We use Grossman seal. These are the two components that make up your obturation. Ideal properties of your core material are the following. It's easy to place in the root canal system. You can seal the canal laterally and apically. It doesn't shrink. It's bactericidal. It's radiopaque, so you can see it on the radiograph clearly. It doesn't irritate periapical tissues. It's easy to remove from the root canal system. Things don't go according to your ideal plan. Let's take, for instance, we put the gutta percha in the canal, and it's a little short. So we can easily take it out if it has this ideal property and redo the obturation to where it should be at the what? Working length, right? At the working length. It doesn't stain the tooth structure because of aesthetics, and it's sterile. Or you can disinfect it. The ideal properties of the sealer are the following: tissue tolerance. No shrinkage, it has a slow setting time, which means you don't have to work really fast in order to get the job done. It's adhesive, radiopaque again, so you can see it on the radiograph. No staining, so we don't want the coronal clinical crown to stain. It doesn't irritate periapical tissues. It's easy to remove from the root canal system. Again, sterile, where it will use it in a sterile environment, and it's aseptic. We want to keep aseptic technique. And again, it doesn't stain any tooth structure at all. So lateral condensation is the golden standard of obturation, and this is the technique that you're going to learn in the lab. There are many other techniques, but this is the basic one that you will learn, and then we'll kind of talk about another technique. So it is the most common technique. It may not fill irregularities to produce a homogeneous mass, and it has the potential for vertical root fractures because of maybe using too much pressure when you're using the spreader in doing this technique. So how do we do the lateral condensation technique? First, you're going to have a master cone. The master cone is the gutta percha cone, the first cone that goes to the working length. And it has to go to the working length. If it's short or if it's long, then we have to make adjustments. It should be the same size or a size smaller, or sometimes it could be larger than the master apical file. It depends upon how conservative or how aggressive you are with your cleaning and shaping. I might be a little conservative when I'm doing my cleaning and shaping. So my master cone might be a size smaller, whereas another faculty member, their cleaning and shaping might be a little bit more aggressive. So their master cone might be the same size as the master apical file, or it might be a size larger. Again, the master cone is the cone that fits at the working length. Number one, it has two criteria. It goes to the working length. And number two, it has a snug fit, what we call tuck back, which means that when you place it in the canal with a light touch, not too light, but you're unable to easily remove it out of the canal. The reason for the tuck back is so that you will have a good apical seal, right? Think of an apical seal is, we have a sink, we have the drain, right? The drain is like our apical foramen, all right? If we put a stopper there over the drain in the sink, then the water that accumulates in the sink won't go down the drain, right? Same principle. We have our canal. We have our apical foramen. We put the gotta perch your cone in the canal. You want a nice tight seal, which is the tug back, so that any type of microorganisms or anything that's embedded within the root canal system won't go past that area to cause, what did we learn this morning? Apical peritonitis, right? So think of it like that. That's the purpose of the master cone. The master cone is the primary key to success for us in obturation. Once you have the master cone and it goes to your working length, number one, and number two, you have your tug back. We're going to take a radiograph to make sure that the master cone is at the working length. This is called the master cone radiograph. Once we know we're good to go, we can move on with our obturation. Okay, so how do we do that? We're going to take the master cone out of the canal. We're going to coat the master cone with the sealer. Okay, so the sealer is used to fill in those little voids and irregularities in the canal. We're going to place the master cone in the canal to the working line. And again, you're gonna check again to make sure you have the tug. Okay? Then you're gonna select the spreader. You're gonna place it in the canal. And then you're going to right beside the master cone. And then you're gonna have, and it should go down to within 1 to 2 millimeters of the working length. But the cones that we have, it's not gonna do that because of the tapering. Try to get it in as far as you can. Okay? And then you're gonna put the spreader in there. Then you're gonna go 180 degrees, like this. It's a constant motion. And I'm gonna show you this. Right? Make sure, and then you get your accessory cones. Your accessory cones are the cones that come after the master cone that you want to fill up the space, the root canal space. So, take the spreader out. This is what this is. The master cone here. You place the spreader inside of there to make space. Take out the spreader, you place the accessory cone. The accessory cone has sealer on it as well. Place the spreader inside of the canal, and then you do your 180 rotation. Again, make sure that the spreader is in the same place each time, because if you put the spreader in different places, you're going to have what we call voids, which are spaces, empty spaces. So in order to alleviate that, because we want to get a nice homogeneous mass together, make sure the spreader is placed in the same location each time. And you do the same thing, the 180 degrees, and make some space. You remove the spreader, and then you go back to this diagram here, C. You're gonna add another accessory cone, and you repeat that until you cannot fit any more accessory cones in the canal. So I'm gonna show you another slide that demonstrates this as well. A is the empty canal. B is where you place your master cone. And the silver dot here represents the spreader. You place the spreader in the canal at 180 degrees. Excuse me. 180 degrees. You remove the spreader. You place your first accessory cone as far down in in the canal as you can, and then you repeat that. You place the spreader 180 degrees, remove the spreader, place another accessory cone, and you continue that until the space is filled. That is called lateral condensation. That's that technique. Once you have finished the obturation, you're going to use your Endo Pro 270. This is an electric heater, and it has tips that come with it. This is the charging cord that goes with it, and I'll show you it attaches on the end to charge it up. And you're going to use this to sear, what we call searing the gutta percha to the CEJ, which is basically the orifice of the canal. So it's important to know your anatomy. We're going to use 230 degrees Celsius temperature, and I'll show you how to change the temperature on the Endo Pro today. Okay. Yes. Yes.
The accessory phones come in different sizes too.
The accessory cone?
Yes.
Yeah, we're gonna provide that for you. Don't worry about that. You guys have the master cones. Okay. This is what it should look like when you're looking down inside of the access prep. This is a pre-molar. So when you're looking inside your access prep, you see how the gutta percha is seared down to the opening of the orifice. That's the opening of the canal. That's where you sear the gutta percha. If you don't sear the gutta percha at that level, you may have staining of the clinical crown, and your patient will not be happy about that. And next, after you do that, then you take your post-op radiograph to check and make sure that you have a nice, dense fill with the gutta percha. Okay. In the lab, once you finish your obturation, you will not place any type of filling or restoration in the access opening. And the reason for that is so that when we do the grading, we'll be able to critique your RCT completely. However, in patient care, when you finish your obturation, you will always place a permanent I should say a definitive restoration. Okay? Glass armor, composite, amalgam, depending upon, what the treatment plan is. Next is the required radiographs for root canal therapy. You have your diagnostics, where you determine your EDA and your working length. And you look and see, can I see the canal? Is the root curved, not curved? Do I have a periapical lesion here or not? Tells us a lot of different information. Your working length is your initial apical file that goes to the working length that is nice and snug. It doesn't move out easily. Because if it's loosey-goosey in the canal, then you're not going to get an accurate working length. And then everything that you're doing is in vain because you didn't follow the steps in the order. Next, you have your master cone. You're gonna check that. If it's at the correct working length, then we can move forward and do our lateral condensation and take our final radiograph.
Obviously irrigate root canal system after instrumentation. Absorbent paper points are used to dry the root canal space before obturation.
All of you have paper points, but if you don't have the right size paper points or you run out or something, just let us know and extra for you, okay?
Drive and root canal with sterile paper points. Gutta percha cones are used to fill the root canal space. Disinfect the master cone and accessory gutta percha cones with sodium hypochlorite.
In patient care, this is extremely important for you to disinfect the gutta percha cones. Because what we want to do is to remove the microbials inside of the root canal system. And sometimes the cones, and we'll talk about that in another lecture, but sometimes the cones have bacteria on them. So we're trying to do as much as possible to decrease that number of bacteria, microbes within the root canal system so that we will have a favorable prognosis and our treatment outcome will be successful.
Select and measure the master cone to the working length. Insert the master cone in the canal to the working length. Check for apical resistance to withdrawal, known as tugback. Place the liquid and powder of the endodontic sealer on the glass slab. Mix the liquid and powder with a spatula to a creamy consistency.
I'm gonna stop right here, okay? When you are mixing the sealer, make sure the sealer, and I say this all the time, no granules are present. It's a nice creamy consistency like butter, or even, when we were in grade school, like kindergarten, and you use the Elmer's glue, that type of consistency, okay? And with the spatula, you should be able to lift it up with the spatula off of the glass slab 1 inch. If it doesn't do that, then it's either too thick or more than likely too much liquid is in the sealer. So you have to add some more powders for the right consistency. But make sure that you mix it up really, really good, and it doesn't have any of those granules. It's nice and creamy.
Obviously irrigate the root canal system after instrumentation. Absorbent paper points are used.
Well, anyway, I'm gonna loop it around when we're explaining, but it goes on, I guess I stopped it too early. It goes through on placing the, master cone, placing the spreader, and how it should look like steps on a ladder when you're placing your accessory cones. When we are doing our assessment for your obturation, please, get in the habit of disinfecting your gutta percha cones. Have faculty to check the master cone that it has the tug back and that it's going to the working lane. And I should reverse that. Have us to check first that it's going to the working lane and then that it has the tug back. Use accessory cones and we'll provide that for you. And, once you finish your obturation, then you can go ahead and check off to see if your obturation is a good filler. Overextension means that the gutta percha is going past the apex. Under extension means that the gutta percha is short of the working length, what it should be. And then make sure you sear the gutta percha at the orifice, which is the CE check. Are there any questions at all? Everybody's good? Okay, let's have a good day.